All right, I'm going to go ahead and get started with some housekeeping so we can get to the good stuff. Welcome to our session today. It's been a while. We took a break for the holiday season. I think we haven't had a meeting since, and our October session was rescheduled, so I don't think we've had a session since September. Thank you all for coming. This is our MHIDD Project Echo. And if you would, just put your name in the chat and your organization or your role. So if you'd like to connect, everybody has that information. And just so you know, we are recording. We record all of our Echo sessions so that we can post them on our Canvas page so we can access them later. If you don't want to be recorded, you can leave at any time. A couple housekeeping things we've always gone over. We have been in the world of Zoom for quite a while now, but if you need to change your name on your profile, there are some instructions here. If you end up needing to change your name on your screen later, you can message one of our Echo Hub team members. We have these backgrounds that are like behind me. They are blue with red dots, where you can message me and I'll send that information. Generally, our Echo sessions involve some sort of conversation about participants or clients. Just as a reminder, we want to make sure that we're protecting individual privacy when we talk about people that we know. So avoid using any identifiable information like their first, middle, or last name, or any information about their family members or close friends. So we'll want to de-identify examples and scenarios as much as we can. If you have a question about information you want to share, you can reach out to me or another one of our Hub team members. This is an Echo session where it's different from a standard webinar. We expect more interactive conversation. We'll start out with our didactic presentation and then move on to a group discussion. It works the best really when everybody participates and everybody contributes to our discussions. We also typically have a case scenario. Today will look a little bit different. We'll have a group discussion about the content. But if you have a case scenario you'd like to cover in a future session, you don't have to talk. You just send the case information to me and I will lead. We would love to have that. You can email it to me or to our MHIDD email. As I mentioned, this involves a didactic presentation, but as well as a group discussion, typically also a case presentation, so we can share our knowledge as a group, sort of a community of practice. This is the email you can send case study information to. I have a PowerPoint template as well to make that really easy. It's mhidd@aggies.usu.edu, and I'll make sure that email gets dropped in the chat as well. We do offer CEUs through the Utah Social Work Association. If you are interested in those, you'll need to fill out our post-session survey. We also offer certificates of attendance if you'd like to pursue CEUs through another avenue. And similarly, you'll need to fill out the post-session survey to request one of those. We do have a Canvas page. Anybody who'd like to join is welcome. You'll need to send an email to our MHIDD@aggies.usu email to request being added. We'll send you a link and get you set up there. We have all of our PowerPoints and recordings, as well as any resources that are shared are kept on that page. We do have a social media page about all of the echoes that are going on here at the Institute. This QR code will take you there, or these are our handles for Instagram and Facebook. Our next session, just a little plug for that, is February 12th. That will be on suicide risk and prevention in individuals with intellectual and developmental disabilities. We have a really awesome presenter coming. We'll also send out a reminder. And now, for our presenters, I'm so excited. We have a group from the National Center for START Services. This is an awesome group with lots of experience. We have a lot to learn today. We have Andrea, Karen, and Micah. Andrea is a licensed clinical social worker with more than 15 years of experience in the field of mental health. She's currently the Director of Research and Quality Assurance at the National Center for START Services and is also an adjunct instructor, professor in the Department of Social Work at the University of New Hampshire. In her work with the NCSS, Andrea oversees and supports START programs with meeting model fidelity and program certification, and oversees the research and evaluation activities of the center. Dr. Karen Wiegle is a clinical psychologist with over 25 years of experience working with people with autism and other developmental disabilities and their families. As the Associate Director for the National Center for START Services, she facilitates program implementation, provides expert training and consultation services, and conducts research. We also have Micah Peace-Orkia, who is a Research and Training Associate at the National Center for START Services. They hold a BA in Integrative Studies with concentrations in Organizational Leadership, Social Justice, and Psychology from Northern Kentucky University. Micah is nearing a decade of service in the disability community and has experience working with other disabled folks across the lifespan and in a wide variety of roles and settings. We're so glad to have you here. I will stop sharing so that you can share yours.
Thank you. Thanks, Rachel. Thank you all for having us. Karen and I were just texting each other about how old we're getting, because I think we're closer to 20 and 30 years now. Holy smokes. Micah, you're probably pushing 35 years. Yeah.
Oh, no.
We'll only admit that to you all. That's it.
That's okay.
So don't tell anybody. Let me see if I can share my screen.
Thank you, Andrea.
Yep. It's my desktop, so don't judge me.
It's a lot of stuff.
You don't judge me.
I'm not judging. I'm just stating a fact.
There we go.
Yay. All right. Thank you guys all for joining today. So glad you're here. And we're going to talk about myths surrounding mental health for people with intellectual and developmental disabilities. So we thought it would be smart to start out with a definition of what a myth is. It's a popular, unfounded, or false belief or notion that has grown up around something or someone, especially one embodying the ideals and institutions of a society or a segment of society. So we know that people with intellectual and developmental disabilities have been marginalized throughout history. So most of the people who have, and institutions within society who have created ideas and knowledge have not included people with intellectual and developmental disabilities. So we're here today to talk about some of these myths and dispel some of them. Next slide, please. We're jumping right in. So the first myth that that is overarching, right, is that people with IDD are immune to mental health concerns, that they're worry-free. And I think, you know, most of the time this is kind of being dispelled, right? I think with time, this is being dispelled. However, if you look at research on the incidence of mental health conditions and how that looks and what that is like for people with intellectual and developmental disabilities is still lacking, hugely lacking. We're working personally, all of us here, to change that and to include people with IDD in the design and implementation of that research. So some of these statistics I have are rather old, and a lot of them are about people with autism in particular, because as you know, right, we've had a great public health campaign around autism over the past 20, 25 years, where it's no longer the mystery that maybe it once was, kind of like type 2 diabetes, right? We kind of generally understand it. No signs and symptoms, Same has happened with autism. And with that came a lot of more research dollars. Still not enough, but we know more about that particular subpopulation of people with intellectual and developmental disabilities. So here are just some statistics that people with IDD have much higher rates of mental health conditions than the general population. That's just a fact. And at least 30% of people with IDD have a lifetime expectancy of experiencing a mental health condition. And 70% or more of children with autism experience significant mental health symptoms, So when we're looking at the specific population, we're getting a lot more particular about information. I doubt there is a disparity, this big of one, between people with IDD in general and people with autism. I think the research is just newer and better. So 40 to 50% of children in clinic settings meet criteria with autism, meet criteria for 2 or more psychiatric conditions. And when mental health conditions occur for people with autism and intellectual disabilities, there's more functional impairment in daily living than there are for neurotypical same age peers. So it is more impactful. And we'll talk about this in a minute. This study done by Buck and colleagues, again, almost 10 years old, 10 years old, we are in 2024, so it is 10 years, looked at lifetime rate of occurrence for adults with autism spectrum disorders. Having 69% of people surveyed said, yes, I have experienced a mental health disorder sometime in my life. Thanks for anticipating. Another myth, people with IDD do not experience a full range of mental health symptoms. Again, this sounds like a gross generalization that I think most mental health practitioners would say that's not true. However, there are a few really common phenomena that occur that lead people who support and or treat people with IDD and mental health needs to really sort of show this myth, and it continues to happen. So the first is called diagnostic overshadowing, and that is the tendency to assign any and all signs and symptoms of mental health conditions, and I'm going to put in here and medical conditions, beware, to a person's intellectual disability. So one example is a young boy I was seeing around 8 years old. He was diagnosed with autism, seeing him and his family in therapy. He began, he had a lot of stress at school, a lot of family stressors. And he began to hallucinate snakes or see snakes coming in his windows, giant snakes at night. And the physician who had previously seen them and then referred them to us said, well, that's probably just part of autism, right? It's like good imagination or special interests. No, this child was experiencing psychotic episodes secondary to depression and anxiety. So we really had to address that, right? But this is a common thing that happens for people. A second one that happens often is just writing something off as behavioral. I think this is a byproduct of the research on behavior analysis and applied behavior analysis, and the fact that that has led to funding nationwide for those services for people with autism and ID, and has become sort of a catch-all, just an expectation that with applied behavior analysis, we can address everything that we see, right? And it must have been learned. Another example I have is an older gentleman. I'm going to call him Ark because he lived in southern Arkansas, and he used a mobile thing he could drive for mobility. I forget the proper name of this, but he called his dog. So he drove dog around, and he ended up, you know, the main reason he was referred for support at start was because he was running over or running into staff and smashing them against the wall with dog. They had a lot of behavior support plans around this, and nothing seemed to be helping. Once we were working with him, the staff person who was most frequently run over also talked about that he was crying a lot throughout the day. She talked about his decreased appetite, his lack of interest in doing things he used to like to do. Nobody had considered depression, right? They were still like, but he needs to stop this behavior. So there's just this tendency to overlook all the other indicators that this really is something more than a learned behavior to get me X, Y, or Z, right? Finally, diagnostic overlap. So oftentimes people don't take into account that there are overlaps in symptoms. And a really obvious example is for a lot of people with autism, some people actually do suffer from OCD, but it is often considered, well, that's just part of autism, right? Or anxiety. That comes along with it. You already have baseline high anxiety, so we just expect that without understanding why this is a particular problem for this person, right? How it is above and beyond the presentation of autism or intellectual disability. So next slide. So how does having an intellectual or developmental disability potentially predispose you for mental health conditions? And this right here is not based on research. This is based on my years of experience in the field. This is what I see happening for a lot of people and how I understand why some people are more predisposed to depression, anxiety, in particular PTSD. So for a lot of people with autism and ID have differences in sensory regulation, may have different understanding of social interactions that are happening around them. And when you think about it, these things are clearly related to our own emotional regulation, right? Our ability to understand what we're feeling, do the self-talk, name our own emotions, decide what to do with them in the moment, understand that sensory input can be part of that. It's very complicated, and most people don't sit around and talk about this. This is little things we pick up from the time we're born. Nobody sits us down, our parents don't have the talk about your sensory regulation and how it impacts your mood, right? We talk about it as it happens, right? What do you need to do to calm down? How do you need to feel better? You can't catch your breath or crying so hard. These sort of things. That may take longer and different uses of language to be able to do for people with differing abilities. Then thought patterns contribute to mental health. Obviously, we all know that, right? And sometimes it's hard to know what people are thinking if they aren't able to tell us. So it's hard for us to understand where thought patterns may be coming from, what might have happened in kindergarten that is still impacting me at age 20, because I learned something there that seems to apply still today, but may not have been an accurate interpretation, or even if it was accurate, it's maybe not the most healthy one for me to hang on to, right? Those of us who are, and this is in general in humanity, less depressed are also less accurate with reality. So just saying, it's a little bit helpful to talk yourself out of that person was mad at me for a good reason. It's like, well, it was their problem. They had a bad day. That's bad. That's better for our health, not to be uncaring, but also to not assign everything to ourselves, right? We also know resilience is associated with health, and these are all factors that are impacted, right? When somebody has an intellectual or developmental disability, resilience can be harder to gain, and that can be associated with medical health conditions, which are more common for people with IDD, negative life experiences, being marginalized because of the differences. When you think about all this, it's kind of amazing if I could meet somebody with an intellectual or developmental disability and they don't have some kind of mental health condition, right? Like that's amazing because you're just set up. I'm sorry, but our society sets people up to experience this just through our expectations of behavior and expectations of other people, which are often not accurate. All right, I'll get off my soapbox. Next slide, please. So what are some, we have to think about common comorbid mental health conditions, and we have to remember that we have to compare the person to themselves, not to somebody else who we knew one time who also had moderate ID and Down syndrome, right? Like that doesn't, it may inform some very general hypotheses, but you really need to compare this person's presentation today and what they're telling you is wrong to themselves, right? To their own baseline, to how they used to function. So I have worked with so many people. One person who came to us in 10 Start 20 years ago, this man came in a wheelchair. It took us a month before we realized 3 months ago he was walking and working and doing physical work. What happened in this decompensation? Nobody in the family mentioned it. They were just like, oh yeah, he's just starting. He was like 58. He should not have been in a wheelchair. He had, that dramatic of a change. It took us a month to figure that out. We were not asking the right questions. We need to say from the outset, when is the last time this person was doing their best and what did that look like, right? That gives you also a big clue as to what's different. How did they used to be? We also need to think about, just like anybody else, what are the mental health conditions that have occurred within this family, immediate and extended, because somebody may have more likelihood of experiencing that same thing. And I always put in here, and I will say it 50 times, we absolutely have to rule out medical conditions first. So very frequently, what we see as a behavior problem or mental health problem is an undiagnosed or undertreated medical condition that somebody may have difficulty letting us know that's exactly what it is. Next myth, mental health treatment doesn't work for people with IDD. So usually there's like one of two extremes in this myth. It's either that, well, there aren't evidence-based treatments, for people with IDD. That just doesn't exist. Or if I just use CBT or whatever it is I'm using, ACT, without accommodations or modifications, I did that and it didn't work. So we're not saying accommodations aren't needed and useful. So here is a list of evidence-based treatments right here. And this is just a few, and actually the most well-documented right here. So skills system, which is a DBT-informed approach by Julie Brown. Most people have heard of that one if you've worked in this field. Beat It is a behavioral activation treatment for people with IDD. Excuse me. Acceptance and commitment therapy is also well researched, the modifications needed for this population. And then Nirb Singh has done a lot of research on biological regulation techniques in this population. So means for reducing arousal, mindfulness, self-soothing. And I put one of the links in to one of his most simple, easy to use techniques that has been very well researched and easy to use with lots of people. So when we think about what are the accommodations we do need, really these considerations work for anybody that we are working with or treating. Obviously, we need to be culturally and linguistically competent with anybody we serve, regardless of having an IDD. It becomes even more important when people present with complex needs that maybe we don't understand and maybe we aren't part of that. We haven't had similar experiences. We need to be even more careful, right? So you have to learn each person's cultural perspective and how it impacts their worldview and functioning. These are obvious to say, not so obvious to do. It takes a lot of time talking and understanding, listening, letting the person talk and or their family talk, or if they can't explain these things to you, watching, observing, learning how each person best communicates. And you got to consider expressive language, receptive, pragmatic language skills, and adjust yours accordingly. I find that more often than not, I speak in the same way oftentimes, regardless of my audience, because I've learned to be more clear, I suppose. And I try to avoid idioms. And there are a lot of things that I used to say and do when I began working in this field. And I'd just see people looking at me like, what are you talking about? You know, and I'd be like, oh, I just caught myself. Or I'd say, what did I say? You know, I don't even know what I said. Another important one is I used to try and tell people, you need to look at me. And finally, I had a kid say, do you want me to look or listen? Because I'm only going to be able to do one. I can't do both. And I was like, oh my God, that's brilliant. Thank you for telling me. So I've never since then said, look at me. I might say, are you listening? You know, but that's not a requirement. It's a great idea to use any kind of special interests to engage and adapt anything you're doing. So I have a lot of kids in the past who were into Pokemon, and anything I could do to make any tool or material, I would print out the Pokemon stuff and insert it into any tools I was trying to use, and that helped. Using the person's language helps. And to consider executive functioning and attention. So you have to adapt the amount of time that you're doing certain activities. A lot of times I use time timers for people, where we negotiate what we're going to do when and for how long, you know, and usually the how long is based on what I know about attention span about that particular person. But we're going to do my thing for this, and then we're going to do your thing for this amount of time, and then we're going to switch to a different activity. So these are just important tips. And I'm trying to read the chat. Talking about mental health, I feel like I need to scream and cry. My son is in junior high. This was to everyone. Okay, yes. High school, and his principal just sent a message saying a junior girl died. Oh no. Yeah. Just awful. I'm really sorry. I'm really sorry. It's really important. I did have one last example of a tool that I've used for years and years. If you could advance the slide just one more. And it can be, I'm sure a lot of you have heard of the incredible 5-point scale. This has been around since 2010, right? And it can be helpful. You can use it for so many things: social issues, anxiety, stress management, helping people communicate their emotions when they may not be able to verbalize them to somebody else. You can use it as a check-in to determine where somebody is and what you may need to do to help them regulate before you begin work, or throughout a school day, for instance. So there's a whole book of different ways you can adapt it for different purposes. So again, I've done the Pokemon faces. I've made it into 1, 3, and 5, or 1, 2, and 3 for people where 5 are too complicated. You don't have to use those faces. You can use any. I've done My Little Pony with people, whatever works for them. I've even used it for adults. One young man who was on a full ride to Carnegie Mellon, and became suicidal and needed to leave school, and we used his words. It was his egregiometer, because the worst he'd ever felt was egregious, right? And so this can be adapted in any way that makes sense for the person. Okay, so I wanted to take a minute and just pay respect to Maria and see, I can't stop sharing. There, thank you. And just see if you wanted to talk about any of this, or if it brought up anything for anybody else that we should.
I cannot talk a lot. I just got the news and I read the message, but I don't know, it's just making me more understand and think about how we need to take this meetings, these classes, these lessons to try to help other people and just realize how important are our kids, not just our kids, but all the kids, you know, to notice. And I don't know, I go in my kids' room every night to check a couple of times and you just never know. So that's all I can say right now, but thank you so much.
Thank you, Maria. Thank you for sharing that. And I'm so sorry. I'm just so sorry. And it is a problem, and we really do have to pay attention. And a lot of kids are suffering. So it seems to be, I don't want to call it an epidemic and overstate it, but it does seem to be happening after the pandemic to really become a challenge. So it is important. And, you know, thinking about grief and loss, trauma that even Maria, your child, is experiencing, I'm sorry. Really important. Does anybody have anything else to say or want to contribute?
I'll just say thank you for, you know, for saying that. I think it's, you know, mental health conditions in general are so highly stigmatized that things like this happen and people don't really, like, it happens in our lives. You might be sitting in a training, you might be sitting in a meeting, you might be at home, like these things happen to us and nobody plans on it. And so I really appreciate you bringing it up. And it's really important that when we collectively as a society, when this comes, you know, I'm not personally affected by this. You know, I don't know this person. I don't know your son. I don't know you, Maria. And also, it's my social responsibility to sort of stop and recognize it too, right? And that's some of what we're talking about today. So this topic actually can't be more perfect, because out of myths comes misinterpretations. Out of misinterpretation comes deeply ingrained beliefs and values. And that can be on a personal level, a family level, and a community level. And that's when it becomes ingrained in our society. And so just by virtue of having this dialogue, we start to break some of that down. And it starts with somebody just sort of throwing it out there, right? And all of us just sitting with it for a minute.
I just want to say thank you, Karen and Andrea and Micah as well for your responses. This is Maria. Thank you for sharing. This is one of the issues that is so important to me personally. I also can say here in Cache Valley where I live, suicide has been a concern. It's been, we've had an increasing rate for a while. So this is something that's very important to me. I'm going to add a few resources in the chat on kind of navigating grief and the space that occurs after a loss by suicide. Ashley, thank you for putting the link to suicide prevention resources. Karen and Andrea, feel free to continue on as you see fit, and Micah as well. Please continue to share as needed. I'll turn it back over to you.
Okay, thank you. Thank you all. And yes, Micah, you are next.
Sure. And before I begin, I just also want to thank and extend lots of care and compassion to Maria for bringing it up, because I think it's a tremendous act of care to speak honestly about these kinds of things, because so many of our struggles and isolation, just like these myths, fester when we don't talk about it. So thank you so much. The main myth that I am here to bust today is the myth that people with IDD cannot play a meaningful role in their own care. And I don't like to talk too much about myths without saying what the real fact is first, because it's kind of like giving the narrative away. So the real fact is that, and Karen kind of set us up for this, ableism, the real fact is that ableism and inaccessible procedures put people at IDD at an inherent disadvantage, and they accentuate existing power differentials, that is, between a provider who's an expert and a person who is consuming and needs help down here. And both ableism and these inaccessible procedures and accentuated power dynamics all work together in a perfect storm to create lots of opportunities for harm. I'm going to speak more specifically about ableism in a couple of slides. But suffice it to say that when you have all of these elements functioning together in a clinical setting, there's so many opportunities for a person to lose their agency, for a person to become, as Karen has discussed, kind of this exaggerated stereotype of all of their worst days and all of the worst elements that they experience of their disability. And when someone is interacting with you, not as a person, not as an active agent or player in your own life, it creates a very inherently traumatizing dynamic wherein people with disabilities, how do I say this? You don't feel like you're a whole person. And this kind of cuts to the heart of what our ethical imperative is as helping professionals, as social workers. It is to acknowledge and to honor someone's whole humanity, and particularly to foster opportunities for a person's voice and for a person's desire in their life, their goals, their interests. It's often as we come to you as a provider for help operationalizing these things, for help finding the resources to facilitate a more meaningful and a more fulfilling life. All people are experts in their own lives, and all people have a right to be involved in decisions that are going to affect our lives. But this is somewhere Karen has spoken about how while we're seeing improvements, we haven't gotten far enough. We haven't gotten enough funding. We haven't achieved everything that we need to understand what will truly make our systems and services as accessible as possible. But we have a start, and there are tools like the PEIS, a self-reporting tool that I and Andrea have been closely involved in creating, that is adapted from a family reporting instrument so that people with disabilities have an opportunity to speak about the services that we've been receiving. And something interesting that we found is that many people with disabilities haven't even been given the courtesy of an honest understanding of why they're receiving treatment. Many people who have so far completed the PEIS believe that they're receiving treatment not for help, not for support, not to make them more self-actualized or better in their lives to enhance their well-being, but because they're bad. They see it as, well, I get kicked out of class a lot, so now I have to come here. Or, well, I can't act like everybody else, so you have to help me. It's very much viewed as a punishment. And that speaks to the context, I think, of ableism that a lot of us with disabilities are forced to exist in. Ableism is a form of discrimination based on disability. It's largely rooted in the idea that there's this certain ideal normal, and that anyone who is disabled should strive toward that normal and receive therapies and rehabilitation toward that end. I'm not saying that those of us with disabilities don't experience impairment or struggle, but what I want you to notice is the inherent value judgment. That if I am disabled and should strive toward that normal, what is implied is that there's something bad about the way that I am, that there's something wrong with me. And it's assumed that it's better to be non-disabled. And in the medical model that we're find ways to work with, or finding models that extend and make our ability to engage with disability a little less pathologizing. The medical model still sometimes treats disability as an outcome worse even than death. And founding all of our models of care, from mental health to other medical and healthcare services, on this inherently dehumanizing value system creates a situation that necessarily takes agency away from people with disabilities and our families, because there's something wrong with us. We couldn't possibly know what we need or how to live. And it places that agency and that control and expertise in the hands of often highly medicalized or academic experts, who may know a whole lot about one aspect of what we're dealing with, but actually are missing many, many parts of it, as Andrea will kind of talk about when she gets into siloed care. And you don't have to be disabled to experience ableism. I'm going to put a link in the chat that I think it's foundational reading for me, but it's going to inform my next slides. Many parents cite their child's diagnosis as a traumatic event, and one of the defining traumas of their lives. This is ableism. Many doctors will deliver a diagnosis of disability, closely followed by the words, "I'm sorry." Parents have been told to let go of their expectations, their dreams for their children. And parents have even in the past been made to feel as if they were the cause or contributor to their child's disability and struggles. So you will very often meet people in your work providing care who will tell you, this individual can't tell you anything, or they don't know, they won't understand. And it is very important that you are sensitive to that in a trauma-informed way, but that you do not take those words at face value. There will be instances when someone struggles to communicate with you. It isn't always down to their disability. And anyone who tells you they can't is someone who has been traumatized into believing that that person is not capable. And so, the existence of the rare person whose disability is so profound that they can't engage with you reciprocally is not a good enough reason to assume that that is the norm for people with IDD, or to reject somebody out of hand, or to skip over engaging with them simply because that's the assumption. You should always speak to people. There will always be people with significant intellectual disabilities or significant communication challenges, but everyone deserves to have their humanity acknowledged with respect, and at least an attempt at engagement or connection. And as I said, we've got a growing range of tools like the PEIS, supported decision-making processes. And I know that many folks, some even at your own university, are deep in the work of adapting other mental health tools. Next slide, please. Another fact that's really important here is, just because it's harder to engage us sometimes doesn't mean that you shouldn't make the effort to do it, because the fact is that people with IDD, and I would argue people regardless of disability status, have better outcomes when they're connected to other people and engaged in their communities. And our communities necessarily include our care. We live mental health challenges, and indeed our own lives, occur in a much larger social context. None of us are islands, and none of us have mental health struggles because of disabilities or because of who we are. They are because of the unique constellation of genetics, of experiences that we have in the world, of resources that are available to us. And we have to be conscious of that. And as Karen set us up with an understanding of, many people with IDD who are seeking mental health care and our families have already experienced significant trauma by way of being marginalized or having many negative disability related experiences. We kind of live in a context where we are constantly compared to other people and we constantly fall short. That's inherently traumatic. And indeed, as Jim Sinclair kind of explains in the article that I've linked in the chat, many of our traumatic experiences have occurred within the context of ableism, and many of our traumas and challenging behaviors and other mental health related experiences are not the direct result of our specific disabilities and impairments, but rather they're consequences of the interaction between the impairments that we live with and the consequences of how we've been treated or the experiences that we've had due to other people's ideas, perceptions, and stigmas around our abilities and what it means to live with our specific disabilities. The next slide, I'm going to just talk about ableism just a little bit. To be really clear, again, I'm not saying that disability doesn't exist or that it's not a problem for people. Impairments and chronic illnesses do cause real difficulty for me every day. But many services and providers overemphasize deficits and any departure from what is considered normal. So that is kind of like what Karen said about diagnostic overshadowing. I talk to myself a lot. It is not a problem for me. It really helps me to organize my thoughts and maintain my executive functioning, but it sure used to make other people super uncomfortable when I was growing up, to the point that they thought I was psychotic. I'm just an autistic person doing something that is very normative and developmentally appropriate for an autistic person. But ableism has this way of valuing or devaluing a person based on how closely our appearance and behavior meets that kind of standard of normal. And this often and unfortunately works in concert with a lot of other forces like racism, sexism, classism, and queerphobia to make it so that there's only like one way that we can be. And if we can't be that way, then we're written off. We can't possibly be a meaningful contributor in our care, let alone our communities, because we're too different. That is ableism. You may be noticing, in fact, that ableism has a lot to do with this, what we're talking about today. And it's a pervasive force in our society. I want you to think about this list of experiences that many people with disabilities have. From government instituted service systems like First Start and home and community-based service systems, to healthcare settings, to educational settings like special ed, to our day-to-day assumptions, interactions, as often shown in our media. Now think about that list and some of the places where people with disabilities are often congregated and even isolated. I've talked a little bit about the stuff that diagnosing physicians do. That's medical, for one. But now just imagine that you have to spend a lot of your childhood in that kind of setting or that kind of dynamic. Okay, now think about the high rates of staff turnover on a lot of those government waiver programs. Think about the insufficient care that people get in a lot of congregate settings or on a lot of waivers. Think about the separation of day programs and the lack of agency, and the same for special education. At my high school, it had its own separate hallway set away from everybody else. And in many ways, that sets the causes and conditions for other social experiences like bullying and exclusion. So we as mental health professionals readily acknowledge that experiencing any one of these things would be traumatic and incredibly harmful to someone's mental health. And yet these are commonplace, so common as to be institutionalized experiences in the lives of people with IDD. This is what I'm talking about when I say that many of our struggles are rooted in how other people have treated us because of our disabilities, rather than in our disabilities themselves. So if we know that on the next slide, then the only option becomes working toward a more anti-ableist model of care. What can we do? Karen has already talked some about practicing cultural and linguistic humility and competent and striving toward competence. And I want to challenge you to understand that that also includes disability. It includes making an effort to get to know us. And Karen gave a really awesome example, actually, when she forgot the word scooter and used instead the word that the man used to refer to his own mobility device, which was dog. People with disabilities do have a culture. We do have our own unique ways of seeing and expressing, and there is a lot to gain when you are willing to put in the effort to learn from those and to kind of put your own expectations and norms, and even on sometimes some levels your comfort kind of on the back burner. Another thing that can help you to do that is to learn about the self-advocacy movement, its history, and today's disability justice framework. Critically, at all moments that you're engaging with us, address people directly. Even if caregivers are your primary informants, there's going to be times when mom really is the guardian, mom really is driving the bus. But it's still very important for a person to reflect back to the person with IDD that they still exist, they're still a part of this process, and they matter too. And remember, you are a part of the system, so advocate. You're not going to be able to solve every problem. It's a big system, and acknowledging that you're part of a system really begins with being honest with yourself about your role and how you access and wield power within it. Acknowledging a power dynamic or acknowledging that you hold power in a situation, it's not a bad thing. It's not hand-wringing. It's nothing you need to feel guilty about. It means accepting responsibility for the impact and the influence that you're able to exercise in your work and in other people's lives. Your goal should be to use your expertise and the power and access that you have through connections, professional resources, the knowledge and wisdom that you have gained to create more opportunities in your clients' lives for connection, for self-advocacy, and for them to exercise agency and choice, however that may be available to them. I'd like to just wrap up really quickly on the next slide by sharing a quote that guides me in my work, both as a self-advocate organizing and in the work we're doing here today. Toni Morrison said, "I tell my students, when you get these jobs that you have been so brilliantly trained for," and I mean, we're in a room right now, we're in a room of experts, of people who are incredibly well educated and trained. But just remember that your real job is that if you are free, you need to free somebody else. If you have some power, then your job is to share that, to empower somebody else. This is not a clock in, clock out, cash your check kind of thing. And I will leave you, I think you're going to get these slides, or you can take a screenshot, but this is some further reading, everything from the history of our mental health system and how it affects people, up to imagining a future that includes all of us. And this includes the voices of both professionals and self-advocates alike. Thank you so much for the time. Pass it over to Andrea.
Thank you, Micah, and Karen too. Some of what I'm going to talk about, I think what you'll start to see if you haven't already is that there's some themes in our discussion today. So I'll touch on a few things and then move along and hit some highlights. So I'm going to cover 3 myths primarily. One that I often hear in my work is, we talk a lot about siloed care, right? We talk a lot about, well, there's the mental health system, there's the IDD system, there's the educational system. And that's just kind of how it is. There's little that I can do. And I don't know that those words have ever come out of my mouth and perhaps never come out of your mouths, but the feeling is there, right? And what I do often hear, and I have had to catch myself too, is, well, that's not my role, right? And that is a function of this sort of perception that we don't have a lot of power in addressing these silos. And like Micah said, and what I often remind each other, what I like to remind ourselves is like, well, guess what, folks? Like, here's a little secret. We're all part of the system. We're all part of these silos. So when we talk about services and systems being siloed, we really can't be doing a lot of this. We got to be doing a lot of this. So my charge to you is to be a Michael Scott, to be a Leslie Knope, right? So here's a meme of Michael Scott from The Office, and he's saying, oh, just so you know, it's not me, it's you, right? And that's what we do as professionals. Sometimes we have so much patience, right? For some things. I'll tell you what we don't have a lot of patience for: each other. And so there's a lot of when we're unsure what to do, this is just human nature, right? When we're unsure what to do, we compartmentalize things, and we compartmentalize them in silos. And then we say, oh, that needs to happen over here, not over here. So, but if you think about, like, I don't know how many Office fans we have or how many Parks and Recs fans we actually have in this room, but Leslie Knope and Michael Scott are movers and shakers. Sometimes they have a lot of power in their little sphere, right? But when you think about it in the grand scheme of things, not so much, right? Michael Scott operates a paper factory or a paper business. He's a manager in Scranton, Pennsylvania. How many of you know what's in Scranton, Pennsylvania? I do, because I drive through it every single time I head home. I'm from upstate New York. It's right up the road. There's not much in Scranton, Pennsylvania, but there is the Joe Biden Parkway now because he's originally from there. Fun fact, guys. So, and same with Leslie Knope. She's from a little community in Indiana, right? So, but what that teaches me is that we all have a responsibility to do something, to do what we can, okay? So that's the first myth. It's not going to let me go. And the first step in starting to understand that and starting to take some power and some responsibility is understanding that everything happens within a cultural context. So what you see here is the Convergence of Cultural Context framework developed by Good et al. At Georgetown University, National Center for Cultural Competence. And what you'll see here in the center is you'll see that the person, right, that the individual sees the world through their own lens. They interact with their family, and then their family is part of a community, and even broader, the socio-political and economic context, right? Our society, what's all around us. And it's like, okay, yeah, no kidding, right? Of course, that's true, right? We've been talking about it for the last hour or so. But what I think is really important to kind of point out is that what you see around it is a whole bunch of systems: healthcare, mental health care, disability services, early intervention, legal system, social services, transportation systems. And so what we ask people to do day in and day out as providers is to figure out how to navigate the cultural norms of each of these systems of care. That's what siloed care is. And that's got to be tough. And we wonder sometimes why families are not as proactive, perhaps, as we might like or we might expect. But if we stop and think about that in the context of this this Convergence of Cultural Context framework, it's like, holy smokes, what I'm asking you to do is to figure out and to decipher and navigate the cultural norms in all of these systems, and then figure out how to connect with people within that. Man, that's a full-time job, right? And it's exhausting. And so part of our role as helping professionals is to recognize that. And once we recognize that, then we put ourselves in a better position to react in sometimes very practical ways. And that's what I'm going to talk about, is like super practical ways of addressing some of this. And so the way that we begin to address breaking down silos, right? Nobody today, none of us in this meeting are gonna like all of a sudden do one thing and all these silos are gonna come crashing down, right? This is part of the infrastructure of our society. It doesn't mean we don't do anything about it though. It means that we do something within the context of what we can control. So we call this systemic collaboration, okay? That's systemic collaboration. What the heck does that mean? That means that is the process of working together and coordinating efforts. Who here wants to admit that they won't work together and that they won't coordinate efforts? You can do this, right? And in the context of mental health care, it really means the coordination of services and resources from those various providers, agencies, and organizations that we saw on the previous slide. Our job as providers is to connect all of those things for individuals and for families, not to expect them to do that on their own. And each member works together to achieve the best possible outcomes for the person. So remember that, best possible outcomes, okay? So what does this look like? I actually want you to think about this for a second. I'm gonna let you sit here for like 15 seconds. I want you to think, okay, let me think of all the systems that I'm part of, personally and professionally. So just start kind of thinking through that. Like I'm part of a family system, I'm part of a school system, I'm part of a university system, I'm part of a service system, I'm part of, that could be a spiritual system, right? All of those things. And then think about, okay, how do I know when those things are functioning optimally? How do I know that things are going well? So when things are going well in my home, there's conversation happening at the dinner table. That's for me. When things aren't going well at home, everyone's annoyed at each other and doesn't make eye contact and they don't want to talk. Okay. So I know that my family system is functioning optimally when everybody around the table is talking to one another, not just at me either. So I'm the mom in this system. So a lot of people talk at me. What I really like to see is talking amongst each other. Okay. And then as a change agent, right, as a Leslie Knope, I'm going to think, okay, I know what it looks like when things are functioning optimally. What do I need to do to keep it that way? What can I do to keep it that way? What is within my control to do? Okay, here's just some examples from an IDD service perspective or a mental health service perspective that you can do that goes a long way, very small things that can go a long way in helping with that systemic collaboration and starting to make some of those shifts. All right, here's another myth. We've all said this, guys. I don't have the expertise to work with people with IDD. I'm going to refer them to a specialist. And the fact is, I'm here to tell you that yes, you do. Yes, you can. There may be times where there's very specific needs that need to be addressed, and you might refer to specialty care. And also, our goal in the helping profession is to do what we can to make seeking, providing, and treating mental health conditions just ordinary care, just regular ordinary care. So yes, the fact is, yes, you can do it because we're working with humans. And I think I am a human, so I might have a little experience here, right? So maybe I do have a little bit of expertise, right? I have some lived experience. And also, just by virtue of your training, you have something to contribute. And what you'll see here on this slide are some best practices for service providers in serving people with IDD and mental health concerns. While there's some training that is required, there's also a lot of humanistic approaches in here, person-centered approaches. Do you guys know Carl Rogers? I don't know him personally, but I love him. So Carl Rogers is, and I can't go through a training, Karen knows this, without talking about Carl Rogers. Carl Rogers is the father of person-centered thinking. He coined that term in the 50s. And we're still talking about how to implement that today. Are you kidding me? Right? So we still have some work to do. But some very smart people talked about these things a very long time ago, and now it's our job to implement them. So Carl Rogers is a humanistic therapist. And that basically essentially means that we're all human beings, and our role is in the helping profession is to promote positive outcomes in whatever way to help people find meaning and to focus on who they are and to find their place. Okay. So what this really means practically for us in the helping profession is that we have to be active listeners. And that especially means between us. Okay. And the way that we do that is we practice what's called unconditional positive regard. And that means that essentially we have to come to the table assuming that every single person is doing the very best that they can with what they've got, period. So if you don't get anything out of this training, I want you to write that phrase down. We are all doing the best that we can with what we've got. If you come to this work with that framework in mind, you will always assume positive intent. When you assume positive intent, then you focus on how to promote positive change as opposed to stopping negative behavior or extinguishing negative experiences. That means you're building on what is strong, okay? And I also want you to become an and person. I don't know if you know what I mean by this. But what's really funny is that when we talk to one another and when we talk to families, we'll often say, oh yeah, I'm a therapist, but I don't have experience working with people with IDD. Oh yes, we have that service, but first we have to figure out if you even meet criteria for that, right? So I encourage you to become an and person. Replace the but, replace the or with an and. Let me practice that with you. Yes, we have that service, and I'd really like to sit down and talk to you about what you might need to make sure that that might work for you and your family. Same exact stinking thing, different message. So if you heard message 1 versus message 2, I wonder how you might feel, right? Anytime you insert a but in that sentence, you essentially negate the first statement. So those are the two things I want you to do. I want you to assume positive intent, and I want you to become an and person, okay? And so we're not going to do this, but this is a really fun activity. And I saw that some people are from the same agency. So I'm going to encourage you to do this. You can do this in groups of 2 or groups of 3. If you're doing this in groups of 3, then groups of 3 are ideal. But what you do is you have one person sit and listen, and the other 2 people for about a minute and a half positively gossip about the other person. So like Micah and I would positively gossip about Karen. And so we'd say not just, oh, I like Karen's sweatshirt, or she has really great hair, both of which she does. But I would say things about Karen, like she was really prepared for this presentation. I really appreciated how she set the stage here. Karen's really funny, and she's also very thoughtful. She took the time to edit our presentation for us after the fact to make sure that Andrea didn't insert typos everywhere, because that's something, see, I'm not going to go there. But anyway, so what this does is you don't need any training to talk nicely about each other, but you do need practice. So the more that you practice it, the more it becomes second nature. And when it becomes second nature, then you end up starting to lead with those things instead of feeling like you have to slap it on the back end, right? So what we want to do as providers is we want to start with the positive. We want to begin with that framework. Now, that doesn't mean that we forget all of the vulnerabilities that a person may have or come to treatment with, right? It doesn't mean that we just forget all of that. So the third myth that I'm going to dive into a little deeper that Karen started to touch on is this is just all behavioral. Well, no kidding. No kidding. Everything I've done in the last hour and 10 minutes, we're running behind, by the way, for the last hour and 10 minutes has been behavioral. I've fixed my hair. I've switched slides for people. I've taken a drink of water. Looking at a problem through this lens is a very simplistic way of seeing humans. No kidding, it's all behavioral. We act in when everything we do is action-based, even when we're sleeping, right? I sleep in a very unique way that's different from Karen, that's different from Micah, right? So we're all behaving 100% of the time. And the reality is that every single one of us experience a host of biomedical concerns and protective factors, psychological, social, and cultural vulnerabilities and protective factors that impact how we see the world. So the assumption is that when conditions to promote wellness are undermined, then we may see challenging behaviors. Those may occur, right? So I put challenging behaviors in quotes because it's not a term that I like to use in my vocabulary, because I worry that it doesn't fully recognize kind of the lived experience and the humanity of the person that I'm talking about. But that's the reality, right? Is that when we undermine well-being, when we undermine wellness, stress can increase. And when stress increases, we're more likely to see externalized signs or symptoms of that stress. That's where challenging behavior comes from. So there are some very practical, positive, wellness-based approaches that we can use. One of them is very simple: empathy and rapport. Those are the core building blocks of any therapeutic relationship. These are based on positive psychology. That is the scientific study of strengths that enable individuals and communities to thrive. So if you want to learn more about positive psychology, look up Marty Seligman. He's the father of positive psychology. And so, like I mentioned, when you focus on strengths and when you focus on empathy, it doesn't mean that you ignore the vulnerabilities that a person brings to the table. All it means is that you view those vulnerabilities in context, that you recognize that there's an individual and an ecological context to everything that we see as helping professionals.
Andrea, I was
Yes.
just going to interrupt for 1 second and say, and it also tells you a great place to start. If you are seeing those positive, you are aware of all the positive factors about the person, their life, their social circle, that's where you capitalize to help, right? To ameliorate the problems. It's just a good point.
Thank you. Thank you. So a couple other things. We also have to remember that communication, that behavior is communication, right? It's all behavioral. It's all behavioral. Everything that we do has a function. And so we have to really think about what is the function of what this person is doing. What does that mean, right? And we also need to think about not just how do we extinguish challenging behaviors, right? But how do we promote things like nutrition, exercise, sleep? I know when I don't get a good night's sleep, I am real grumpy, folks, really grumpy. And so, but for some reason, when we're serving people with IDD and mental health issues, we don't always think about those practical things. We need to also promote experiences that are rewarding to the person. We can often turn things around with heightened exposure to fun, to things that mean something to somebody that's not contingent on behavior. So if I'm having a bad day and I'm really stressed and someone says to me, you can't do that. You can't do that. You didn't behave. You can't go to the gym. You didn't behave. Well, shoot, like perhaps going to the gym, for me, going to the gym is a coping mechanism. Going for a walk is a coping mechanism. So you're going to ask me to cope with whatever's happening to me and not behave in a way that you consider negatively, but you're going to tell me I can't go to the gym. So my cup is now empty. And when my cup is empty, I'm starting to think, well, what the heck here? Why should I act in a way that's a little bit, more socially acceptable if my cup is empty here? So what we need to do is we need to make sure that people have opportunities for positive experiences that are not contingent on how they behave. Okay. We need to focus on natural consequences. We also have a responsibility to shift the environmental context as well. So we can't ask people to cope with something if we're not also considering what's going on around them. It won't let me go through. Almost done, folks, I promise. So here's a few things that don't help. And what you'll see is that some of these are the antithesis of what we just talked about. I'll tell you what doesn't help, assuming that all behavior is intentional or deliberate, and that the person has control over their behavior in stressful situations. I'm a crier, okay? Full disclosure, I'm a crier. I cry when I'm angry. I cry when I'm sad. I cry when I'm happy. I cry when I'm surprised. I cry when I'm scared. You name it, I will cry. I have no control over it. I've tried. And it really frustrates me when I start to cry, especially when I'm angry, because that's the last thing I want to do, but it just happens. I don't have any control over that. That's my stress response. If someone said, well, you can't cry, every time you cry, you're going to get a tick. You know, we're going to track how many times Andrea cries, and she just needs to stop that crying. That's going to really put me in a tough spot because I can't help it. Frankly, it's going to probably make me cry. But I can't help it. So, and if we are coming to the situation, to our work, with the assumption that everyone is doing the very best that they can with what they've got, then we cannot take it personally. We absolutely cannot, because it very likely has very little to do about you personally. And from a parenting perspective, I know like sometimes like, you know, my kids will do something and it'll really grind my gears. And we'll get in kind of a little tiff, and they'll go take a break, and 2 minutes later, they're fine. Everything's fine. It's over. I'm still upset about it. Me, the caregiver, right? That's about me. That's because I took it personally. And the reality is it's not personal. Oftentimes it's developmental. Oftentimes it's the lens in which people see things. Oftentimes it's their perception. Sometimes it's just their body's way of dealing with something, none of which has anything to do with me. Okay. Another thing that does not help that I'll mention is redirection on its own. You can redirect, but you better reassure first. Reassurance and redirection are best buds. Redirection is only effective if you first provide reassurance. And lastly, what doesn't help is the expectation that processing the incident or processing the trauma or processing the experience will help with the meltdown, will help the person learn a lesson. It doesn't work. It's like if you're in therapy and all you do is talk, if you're there because you feel depressed and all you do in therapy is talk about how depressed you feel, how do you think you're going to feel when you leave? Pretty stinking depressed, right? So processing through the negative experience will not decrease the challenges. So do I have time, Rachel? Okay.
Yeah, I think this is a great way to wrap it up, actually.
Awesome. Okay. All right. So I have a situation I want to tell you about. I want to tell you about Emily. Emily is a person that I worked with. She was served by a START program, and we didn't talk at all about START, but START is a crisis prevention and intervention service in the community, and they provide coordination, and they also provide emergency services, one of which is a resource center, which is like a crisis center. So people who are experiencing crisis in the community in their homes will come to the resource center for a little while. So what I learned about Emily when she was referred to START was that she lived with her family in a small college town. She was really funny and loved to explore, like absolutely loved it, and loved to get around using public transportation. She lives in my town and she knows the public transport system much better than I do. So she is able to navigate the entire community independently. She was diagnosed with moderate ID. She was autistic. She was diagnosed with OCD and had a rule out. This is kind of, an old school rule out of depressive disorder. And the reason that she came to START was because there was an increase in aggression at her day program. She actually was suspended, and there was an increase in aggression toward her parents. She wasn't sleeping. Her eating got really irregular. And there was an increase in anxiety. This is what the family said. There's an increase in anxiety. There's some recent medication changes as well. So she came to START And we began to assess for anxiety and depression. And she, when she got to our center, she started pulling the fire alarm like multiple times a day. And when I say multiple times a day, I mean like we had to station people at the fire alarms to prevent Emily from getting there, because every single time she pulled the fire alarm, the fire marshal had to come. And so at some point he was like, listen, you got to get this under control or we're going to shut you down. They was not pleased. So we thought, maybe she's pulling the fire alarm because she's anxious. This is a new place. She doesn't really want to be here. She's anxious. So we tried we actually made her own fire alarm for her so she could carry it around and she could push the button and it would do like a little bling. She didn't want anything to do with that. She did not want that fire alarm. We thought that maybe, so we assessed for anxiety. We tried to do some mindfulness and relaxation with her, which helped, which was good. She reported that she liked it, but it didn't stop her from pushing the fire alarm. We could not figure this out. We tried medication changes. We actually got her a light box because it was starting to get to be winter time. So the days were shorter. So we thought maybe she needed some more, vitamin D. None of these things helped. So here's our fire alarm. So what do you see on this fire alarm? You see the word fire, and you also see the word pull. We were on our triage call one day. We have a daily triage, and the resource center director, we said, how's Emily doing? How's it going? And she's like, oh, it's not a problem anymore. This was like 2 weeks worth of assessment. We did behavior tracking, we assessed sleep, we did all of these things. We created her own light box, or we got her a light box. We created her own fire drill button. We did everything. We actually took her to a psychiatry appointment, and we had to bring 5 staff because there were 5 different fire alarms. Okay. So we're on triage, and the resource center director says, oh, it's not a problem anymore. She's not touching the fire alarm. Like, what do you mean she's not touching the fire alarm? She's like, oh yeah, she's not touching anymore. I put a sticky note on it that said, do not pull. She was pulling the fire alarm because it said pull. So this is a perfect example of making assumptions, of overcomplicating a situation, and also and diagnostic overshadowing, frankly. We assumed that because she had moderate ID, she was autistic, and she had a history of anxiety and depression, that certainly it was depression. And very simply, it said, do not pull. So from that point forward, we just had a sticky note on the fire alarm that said, do not pull, and she never touched the stinking thing again, ever. So what did that tell us? You need to get to know the person as much as you can. If you have met one person with IDD, you have met one person with IDD. Okay. So do not make assumptions. Take in all information objectively. What we did was we assigned meaning to the term anxiety and to the term depression. And we saw it through our lens without first understanding what that meant for somebody else. Do not rule out simple solutions. The reality is you do have the expertise. You can do this. Use common sense. We all have common sense. You can do this. And do not be too quick to attribute everything or nothing to a mental health condition. So do not live in that spectrum, right? Don't do it. I'm not going to let you. Work your way to the middle there. So again, the last thing I'm going to say to you is assume that every single person is doing the very best that they can with what they've got, period. And using that framework, you will put yourself in such a position to make a positive change for people and be able to dispel some of these myths that have just become so deeply ingrained in how we think. So it's our collective job to challenge that thinking.
Awesome. Thank you so much, Andrea. I think that was a great way to wrap that up with that clinical example and from your own personal experience too, just hearing how that process went. So that was perfect timing. You know what? I think that was excellent. Foregoing our group discussion, I think was fine. I think the clinical piece worked out great. Thank you so much, Karen, Micah, Andrea, and everyone who attended today. We'll have a PDF of the slides on our Canvas page. We'll also have this recording and all the resources that were shared in the chat. I'm going to pull and have those available on the Canvas page as well. Thanks again, you guys. You're welcome to hang out until 12:30 if anyone has questions or comments. We'll close the link then.